Hello everyone. Today's topic is pain management, and these are the learning outcomes. So before we really get into management of pain, either acute or chronic, let's very briefly talk about the assessment of pain. Well, as we know that pain is very subjective, so one of the scales that we use is a scale of 0 to 10. This scale is often used for a client who are either alert and oriented. Most of the time these are adult patient, and they're able to verbalize the pain. So 0 is no pain and 10 is the worst possible pain. And remember, pain is always a subjective. If patient tells you that the pain is a 9 out of 10, even if you disagree with that number, do not come up with your own number. You always document what the patient tells you. So you can say subjective, patient states 9 out of 10 left arm pain or whatever the location is. Now under objective, this is where you can very professionally, you can make a statement if you disagree. Don't say that I disagree, simply say upon entering into the patient room, patient was resting comfortably, or patient was watching TV, or patient was able to have a conversation without any distress, patient was not in any acute distress, and so forth. So just document what you observe. If you have a child or any maybe adult who's not able to verbalize or who is not able to rate pain using 0 to 10 scale, then you can use a FACES pain rating scale. All right. Okay, so let's say that you have a patient who tells you that he is in pain. Then what is the next step? So before I really talk about assessing someone's pain, let me make a point here is that it is a best practice to adopt some kind of a mnemonic to assess a symptom. And right now in front of you, I have two options, old cart or PQRST. My go-to mnemonic is old cart, but one is not superior than the other. Review one and stick with that, and if it works for you, great. If it doesn't, and then perhaps adopt the other one. Now the beauty about these two mnemonics is that they work in any given setting. It doesn't have to be pain. It can be nausea, vomiting, it can be a chest pain, depression, anxiety. It doesn't matter what symptom you have, you should be able to apply this mnemonic in any given setting. So for example, let's say you have a client who comes in with a pain, let's say. So I'm gonna say a 25-year-old male with pain. Okay, and that's all we know, right? Okay, so so real quick, I'm gonna ask this person, can you please tell me when did these symptoms start? So I'm looking for the onset. So let's say the patient tells you 3 days ago, or maybe it's 3 weeks ago or 3 months ago. So now we are trying to differentiate acute pain from a chronic pain. Rule of thumb is if symptoms are less than 6 months, sort of 6 months, then it's acute pain. So if you have symptoms more than going on for more than 6 months or so, then that would be considered a chronic pain. So just a quick rule of thumb, if you will. All right, then the second is location. As we know, location is important. Location, right? Now, chest pain is a different. Pain in the chest area is a different, especially with the pathophysiology standpoint of view and the management, versus if it's appendix pain. Appendix pain is different from gallbladder pain. Location is different, right? And knee pain is going to be totally different than your maybe nerve pain, if you will, right? So the point here is make sure you ask about the location. Headaches are different than stomach aches, right? So when you have a location, and if that body part comes in a pair, if you will, then we must identify the correct location. For example, do not simply say leg pain. Well, we have two legs. Is this a right leg or left leg? Okay, right right ear or left ear, if it's earache, right? And also with the abdomen, do not simply say abdominal. Try your best to find out if it's a right lower quadrant versus right upper quadrant, because right upper quadrant is going to give you more of a liver and gallbladder type of issue, versus right lower, perhaps we are dealing with appendix. So location is very, very important. So don't be generic, okay? Then duration. So if the patient tells you this has been going on for the past 3 weeks, let's say, or 3 days or 3 months, but I understand that, but is this ongoing, or does it come and go, or when you have that episode, for how long does that episode last? So duration would be 15 minutes, 30 minutes, 5 minutes. Like a chest pain is going to be for a couple of seconds or a minute or so, right? Versus maybe knee pain, you can say, gosh, it lasts all night long. I was not able to sleep. So and it's been going on for the past 3 weeks. Does it make sense? So that's what the duration is. Now, how about C? Can you really further describe that? Is this pain dull versus sharp? So like a body ache or headache, like a dull headache versus a sharp, worst pain ever, 10 out of 10 headache. That would be a problematic, right? Versus, let's say it's a bilateral feet, and the patient is describing this as a numbness and tingling. Now that's a neuropathic pain, right? The treatment plan for neuropathic pain is different than a stabbing pain, if you will, like or chest tightness. So do not put words into someone's mouth, if you will, but ask them to try their best to describe the pain. So for example, if you have, let's say, a 45-year-old who's diabetic and telling you that I have a numbness and tingling in my feet, your thought process at that time is diabetic neuropathy, right? Versus somebody stepped on a broken glass, let's say, and they are going to have a pain that's very, very sharp. Okay, let's see. With A, aggravating factors. Now, aggravating factors is what makes the pain worse. So when I walk, when I touch my knee or my ankle, wherever that pain is, right? When I exercise, when I run, it makes it worse. And I also use A as alleviating factors. What makes it better? When I apply ice, heat, massage, when I drink tea, or when I take some medication, whatever the case is, right? So aggravating and alleviating, I combine those two together under same category, if you will. Radiate, does the pain radiate or is it localized? For example, if it's ankle pain and patient can literally touch the area, and pain is very localized, versus if the patient tells you, I don't know, like left or maybe right lower quadrant, like towards the appendix area, but it tells you that the pain is going towards, I don't know, maybe groin area. So are we talking about a hernia now, or it goes all the way towards the maybe, I don't know, belly button area? Same thing with the chest pain. Does it radiate towards the shoulder? And even knee pain, does it go all the way down to my leg? Do we have radiation, or is it localized pain? And I also use R for rating, by the way. This is the time, and can you rate on scale of 0 to 10? So 6 out of 10 or whatever the case is. Okay. Then treatment. What have you tried so far? Again, maybe over-the-counter medication or heat and massage and so forth. All right, so as I mentioned earlier, you adopt one, either old card or PQRST, but the principle is the same. Doesn't matter which one you do. I have seen a lot of people doing PQRST, especially for chest pain. Okay. Why is this important? Why are we talking about pain management? And I'm going to ask you this question, and you can pause for 3 seconds and see if you can answer this. According to you, what do you think is the most common cause of job-related disability among adult patients here in our country, here in the US? So I'll give you 3 seconds to pause, and the answer is lower back pain. It often occur between the ages of 30 to 50 due to the aging process and not enough exercise. A lot of patients, especially in the outpatient, young adults are coming for some kind of pain management or management of lower back pain. And we have a lot of clients on some kind of either opioids or non-opioids management of pain. So very, very important from a clinical standpoint of view. Okay, so when you have a client on pain management or any medication for that matter, we know that medications, even if they are over the counter, they either have side effects or adverse effect, right? So we as a healthcare providers, healthcare clinicians, we play a very important role in preventing and identifying and managing those adverse drug effects. According to one study, approximately 1 in 7 hospitalized patients experience an adverse drug reaction, and that's a very high number if you think about it. And the most common drugs that are associated with these adverse events are diuretics and opioids analgesic that we're going to talk about today, and of course anticoagulant medications as well. So very, very important concept. All right, so let's talk about interventions now. As we know that in medicine, we usually start off with non-pharmacological interventions first. And when I talk about a non-pharmacological interventions, I usually think of overall lifestyle changes. However, please be careful that any interventions that we prescribe or we recommend should be appropriate and highly individualized. What do I mean by that? Well, if you have a patient with acute pain, then we are not going to pick lifestyle changes as a first line treatment. So can you imagine if you have a client with a chest pain, acute chest pain, or a broken ankle, then non-pharmacological interventions such as diet, exercise is not first line. So this is good for anything that's chronic back pain, maybe diabetes, CHF, hypertension, just overall lifestyle changes are usually for long-term issues, right? Okay, so if you have an acute patient, then usually we start off with pharmacological interventions. For acute, maybe massage, heat or cold applications. Some patients get a benefit from either acupressure, acupuncture, yoga, music therapy is wonderful, laughter therapy. I have yoga here twice. That tells you how important that is. Of course, it's a typo. Okay, meditation, that's another wonderful non-pharmacological interventions. And physical therapy. I prescribe a PT a lot actually, for both for acute and for chronic, like a chronic back pain, or for acute setting for rehab, like a knee replacement, hip replacement, and so forth. All right, okay, so for the pharmacological interventions, we have options, so that's always a good thing. There's a concept of step-up approach, if you will. This is like a clinical ladder. On the bottom, we have non-pharmacological intervention. So that was a step 1. We just talked about that, lifestyle modification, exercise, and so forth. If that does not help, the step 2 would be starting pharmacological interventions with the non-opioids. So non-opioids are most of the time over-the-counter medications such as acetaminophen, Tylenol, aspirin, NSAID such as Advil, Motrin, and so forth. Then we have, if the pain is not getting better, then the third step would be opioids. So these are controlled drugs, narcotics, examples, morphine, codeine, hydrocodone, and so forth. And then sometimes we like to add some other drugs, something that we called adjuvant analgesics. These are drugs from a different classification that helps manage pain. For example, maybe antidepressant medication. One example I can think of right now is a Cymbalta that helps with all different types of pains, if you will, neuropathic pain, pain with the depression, musculoskeletal pain, and so forth. And sometimes anti-seizure medications can help with the pain, and so forth. So that would be, and sometimes we like to mix, not a mix, I shouldn't say, but maybe add two agents, one from maybe antidepressant category and then one from a non-opioids, maybe like acetaminophen or maybe Motrin, and plus minus one agent from opioids. So some patients with a complex pain or chronic pain may need more than one medication. Well, then we have way too many medications to pick from. So which one do we pick? Well, that's a skill, and the answer is it depends. It depends on the patient's symptoms. It depends on the other comorbidities that this patient have. So this is really a truly individualized treatment. But again, rule of thumb, we start off with non-opioids first. So we're going to start off with non-opioid medications such as acetaminophen, aspirin, and NSAID, which is Advil, Motrin, and so forth. Now, in order to understand the mechanism of action for those three drug classifications, I am going to introduce a concept of prostaglandins. So please understand that we have enzyme called a cyclooxygenase or COX enzyme, and these enzymes will produce a hormone, a substance called prostaglandins. These hormones are found pretty much in every tissue, bone, stomach, blood vessels, and so forth. They were first discovered in the prostate gland, and that's where the name came from, prostaglandins. But later we realized that these hormones are present pretty much throughout the body, but we never changed the name though, and that's okay. But it's such a misnomer. So okay, so going back to the enzyme, there are two types of cyclooxygenase, COX-1 and COX-2, and both of them, COX-1 and COX-2, will produce prostaglandins, which is a hormone. Now, the COX-1 is found in the blood vessel, stomach, and in the kidneys and so forth, and COX-2 are primarily present in the brain and kidney and bone. And they will release prostaglandin, as I said before. Now, the function of a prostaglandin varies based on their location. If the prostaglandins are present in the stomach, let's say, their role is to protect the lining of the stomach. Okay, so GI protection, and same thing with the renal protection. So you know that we have very high level of hydrochloric acid in the stomach. So one of the ways we protect our stomach lining from getting a stomach ulcer is with the help of prostaglandins. So you can say prostaglandin provides GI or a renal protection. Now, if prostaglandins are present in the in the blood vessels, I shouldn't say if, I should say when they're present in the blood vessel, they will increase platelet aggregation. Recall from anticoagulant lecture that anytime we have injured blood vessel platelet, they have a natural affinity towards towards the injured blood vessel, if you will, and their role is to develop a blood clot so that we do not bleed to death. So it's a good thing, right? Now, prostaglandins are going to increase that process, enhance that platelet aggregation process so that we can make that blood clot. Thromboxane A2, a type of enzyme, is a very potent vasoconstrictor that is produced by the platelet when they aggregate. So the point I'm trying to make here is that we form blood clot with the help of a prostaglandins, a type of hormone. And number three, they also increase inflammation or pain. When these prostaglandins are present in the brain, in the central nervous system, they will register pain and inflammation. And that's a good thing. We should be able to register pain. And can you imagine if you stepped on a broken glass and you never knew that it was painful, and you will keep walking and not take care of that injury? That would be bad. That will cause infection and possible maybe amputation and so forth. So pain, inflammation, and even fever is a good thing in a way, that so that we can sit down, assess, and intervene, right? So please understand the role of prostaglandin depends on the location. It can protect GI or renal lining, if you will, and helps with the blood clot, and increased level of prostaglandin will cause inflammation or pain. Okay, so with that understanding, let's talk about our first drug, which is acetaminophen, and a brand name is Tylenol. The classification for this drug is antipyretic and analgesic. That tells you that it has two indications. Antipyretic means it's going to decrease the fever and, of course, pain management under analgesic category. The mechanism of action is, for pain, it is not clear. However, we believe that this medication will inhibit prostaglandin synthesis in the central nervous system, CNS, but does not inhibit peripheral prostaglandin synthesis. What do I mean by that? Remember, we talked about the role of prostaglandins in the central nervous system, that it can cause pain, right? So if we are going to inhibit prostaglandin in the central nervous system, we are going to minimize registration of pain, if you will, right? It will not treat the cause, though. If you stepped on a broken glass and your ankle or your foot is in pain and bleeding, medication will just help you with the pain part, right? By inhibiting the prostaglandins in the central nervous system, but you still have to take care of that injury. So be very, very careful with that part. Okay, so but it doesn't do anything with peripheral, so it has no impact in the blood vessels or in the stomach. In other words, it's not going to inhibit prostaglandin synthesis in the lining of the stomach, or is not gonna increase platelet aggregation, has no effect, unlike aspirin. So I'm giving you a clue here that aspirin will have impact on both central nervous system and in the peripheral prostaglandin synthesis. We'll talk about aspirin in a minute. So because this drug has no impact in the peripheral prostaglandin synthesis, this is not a good agent for anti-inflammation standpoint of view. So if I need to treat someone's inflammation, then acetaminophen is not a good drug. If I'm going to treat someone's pain and fever, then this is a go-to drug. So remember, pain, you are going to decrease or inhibit prostaglandin in the central nervous system. Now for the fever, it will decrease the fever through direct action on the hypothalamic Remember, hypothalamic is where the something that we call the heat regulating center. So we will lower the set point of the heat to normal, if you will. And acetaminophen will do that by inhibiting the action of cytokinase on heat regulating centers. Also, on top of that, lowering the set point to normal, it will also cause vasodilation, and that's how you get rid of excess heat, if you will, and you sweat. So again, good agent for pain and fever, but not a great agent for inflammation standpoint of view. Now, the interesting thing about acetaminophen is that it has it comes in various dosages and routes. So you can have PO versus rectal, liquid versus a solution, solution versus tablet or capsule, if you will, a caplet. If you have a client with high fever, I highly recommend rectal suppository. Rule of thumb is for healthy individual adult, max dose is 4 gram per day per 24 hours, and for geriatric patient, we try our best to use less than 3 gram in 24 hours. If you have a client with overdose, either intentional or accidental, client may experience nausea, vomiting, maybe some excess amount of acetaminophen, of course. If the entire bottle or so, or multiple tablets, you can see bleeding, liver and renal failure. This drug is metabolized in liver, so that's where you will see a lot of bleeding because of, remember, one of the role of liver is help with clotting factors and so forth. Okay, we might have to do gastric lavage within 4 hours of ingesting the drug, in extreme cases, of course, right? Not every patient who comes into the ER with acetaminophen overdose will go through gastric lavage, by the way. Sometimes we can just keep an eye on these patients and monitor them and look at their blood work and their renal status and start hydration and so forth. But if we need to, of course, we will do the gastric lavage or activate a charcoal. And plus minus role of antidote, stilcystine can be given either PO or through NG tube to reverse the effect of acetaminophen. But in general, again, acetaminophen is considered very safe when taken as directed, and it's over-the-counter medications, as we know. Okay, so the next drug is acetylsalicylic acid, which is a generic name for aspirin. Aspirin is a brand name. The difference between aspirin and Tylenol is that, remember, Tylenol works primarily in the central nervous system. It inhibits prostaglandin in the CNS, whereas aspirin will inhibit prostaglandin throughout the body, if you will. And remember, the role of prostaglandin depends on the location. So if I tell you that aspirin is used to manage pain, and that tells you that it will actually decrease inflammation and pain because it actually inhibit prostaglandin CNS and peripherally as well, right? So if you have a client with, let's say, chronic use of aspirin, that means that prostaglandins will be inhibited in the GI tract as well, in the renal lining as well. So if the stomach lining is, I'm telling you, is protected by the prostaglandin so that we do not develop stomach ulcer, but the patient is taking aspirin for longer duration because of either pain or inflammation for whatever reason, that patient will be at risk of developing stomach ulcer and or renal injury, renal failure, I should say. Another interesting point about aspirin is that, you know how I mentioned earlier that prostaglandin will increase platelet aggregation to cause a blood clot, and that's a good thing. However, I'm not saying, by the way, I'm not saying that to have too many blood clot is a good thing. So it's a good thing when you need to make a clot. But if you are at higher risk of developing blood clot, we can actually prevent that by inhibiting platelets with the help of aspirin. So people who are at higher risk, like a coronary issues, and they need to be on something that we call a blood thinner, if you will. And so we can use baby aspirin, like 81 milligram or so, as a blood thinner, which is not a medical terminology, by the way. So what we are trying to do is we are going to inhibit prostaglandin in the blood vessels to decrease at that time, decrease the platelet aggregation so that we can prevent blood clot. Now, so that means that they will be also at higher risk for bleeding if they take too much or they have some other medication that can cause increased bleeding as well, like NSAID, or maybe they are on Plavix at the same time. So the point I'm trying to make here is aspirin will help with the pain, fever, and inflammation. But the side effects are, because we are going to inhibit prostaglandins everywhere, we are going to cause some GI issues, renal issues, and putting the patient for increased risk of bleeding. But that can be used in a therapeutic way, that if the patient is at high risk of blood clot, we can use baby aspirin to minimize that risk. Because platelet, their average lifespan is about a week or so. So when you have a client who is scheduled for surgery, we ask that patient to hold aspirin at least for 5 to 7 days, so that we can reverse the effect of those in prostaglandins that were inhibited, so that we do not cause heavy bleeding during surgery or after surgery. Let's see. So we talked about inflammation, we talked about fever. Good. Okay. So now you know why aspirin and NSAID, same thing with NSAID, they produce a GI adverse effect and acetaminophen does not. So and now you know why we do not prescribe Tylenol as a blood thinner, if you will, right? Because acetaminophen does not have any impact, or has a very less effect, minimum effect on peripheral prostaglandins. So let's talk about two important concepts with aspirin. Number one is contraindication. Now, generally speaking, rule of thumb is that children should not be taking aspirin. It is not a good drug for a child or adolescent. And the reason behind this is a risk of Reye syndrome. Reye syndrome is actually very rare, but when it happens, it can be life-threatening. So what happened is when you have a child who had a recent viral infection, let's say like a chicken pox or flu, and then if child ended up taking aspirin, we can damage their liver and can have like a brain damage as well. Encephalopathy, encephalo means brain, and pathy is like abnormal, right? And so complete liver damage, the patient may have a seizures because of that brain insult, if you will, and death. So it is not a good drug for a child. So as we know that when you have a child with a pain or fever, we usually recommend acetaminophen, Tylenol, not aspirin. So please remember that concept. Now, second concept of aspirin is overdose, something that we called salicylism or salicylate toxicity. So if you have a client who either, again, intentionally or accidentally took a bottle of aspirin, may present with nausea, vomiting, dizziness, drowsiness, some visual changes, and tinnitus, ringing in the ears, hyperventilation, confusion or altered mental status, you can say, delirium, seizures. When you have a client with, especially in the ER, again, observe, keep an eye, and decide the need for gastric lavage, just like we talked about acetaminophen. Not every patient is going to get that treatment. Sometimes patients are stable and we can just keep an eye on them, but do the lab work and then plus minus activated charcoal, IV sodium bicarbonate to make their urine more alkaline. Remember, when you take aspirin, the urine is going to be acidic. So we may need to go ahead with hemodialysis based on their pH levels, and or maybe overall the patient is declining. So these are all the options, but not every patient who comes in the ER with aspirin overdose will go through hemodialysis or need gastric lavage. Okay, third and the last agent under the same mechanism of action, which was to inhibit prostaglandin, is a drug called NSAIDs. So it's a category. NSAID stands for non-steroidal anti-inflammatory drugs. So it's a non-steroidal that tells you that these are not steroids drugs, right? But they help with inflammation. So the first one we did was that shared the same mechanism of similar mechanism of action was acetaminophen. Second was aspirin, and third classification is NSAIDs. And the most common example that you are familiar with is ibuprofen. So the brand names would be like Advil, Motrin, and so forth. Naproxen is a good one as well. Okay, because they share the same mechanism of action with aspirin, they're going to carry the same side effect profile, if you will. So remember, if you're going to block the effect of prostaglandins in the stomach, that means you are going to increase the risk of bleeding or stomach ulcer. So take NSAIDs with food, just like you would take NSAID aspirin with the food as well. We need to keep an eye on renal function because you're going to inhibit prostaglandins in the kidneys as well. So we check BUN and creatinine for these patients. Generally speaking, these medications should be avoided in older population, in elderly patients, because of their renal function is impaired to begin with. So we have to be very, very careful. But to be honest with you, these are the patients who need some kind of a pain medication for chronic pain. And these are the patients who are unfortunately also on aspirin because of blood clotting issues, or they take aspirin to protect from like a cardiovascular standpoint, if you like, they're on a baby aspirin as a blood thinner, if you will, right? So very high risk client, elderly patient. You have to be very careful with their both with the liver status and renal status for those patients. Okay, another interesting drug is celecoxib, or Celebrex is the brand name. Celebrex is a COX-2 inhibitor. So that tells you that if it doesn't have effect on COX-1, then you're not going to see any GI effect. So these are the patients who have either stomach ulcer or high risk of bleeding, then perhaps we can consider Celebrex. It is more expensive, but it carries the same risk for renal and some cardiac issues as well. As a matter of fact, there's a black box warning for Celebrex that it can increase a serious and some potential fatal cardiovascular thrombolytic event. So we have to be careful with a patient who has a history of MI or a stroke. So that would be a problem. Okay, and then the last drug here is ketorolac or Toradol. This drug is given to manage the pain for like a short-term goal, if you will, for 3 to 5 days or so. Usually we give Toradol injections, maybe in the ER, but this is not something that the patient is going to be on for long term. If you need to manage a long-term treatment, acetaminophen is a good one, as long as we stay less than 3 grams or so, or some muscle relaxant. We'll talk about them in a few minutes. So let's say that we have a client whose pain is not managed with anything that we have talked so far, with the non-pharmacological interventions they have tried and nothing helped. They tried acetaminophen and maybe NSAID, and they're still in pain. So the next step will be potential adding narcotics or opioids. So the way these medications work, there are 3 main receptors: mu receptors, kappa receptors, and delta receptors. So remember, when you touch something that is hot, the message from your fingertips, let's say, or something that's sharp or painful, the message will travel from the peripheral towards the central nervous system, towards the brain. And the brain is going to register the pain, if you will, right? These medications, opioids, they will bind at these receptors in a way that if these receptors, let's say mu receptor, is not available because the medication is sitting there, then the pain cannot be registered. There's nothing that you can bind because the receptor is occupied by these medications. So in other words, the brain is not gonna think that you are in pain, or brain is not gonna register pain. Okay, so the 3 receptors, as I mentioned, mu receptors, kappa and delta, and these are the reasons why you see not just the pain management effect, therapeutic effect, but also the side effect also come from the same receptors. So you see respiratory depression here, or physical dependency, sedation with the kappa receptors, and sometimes you can have a client who's start hallucinating, and that comes from delta receptors. And all of these drugs that we are going to talk about now, they pretty much come from opium. These are the natural opioids that come from opium, and which is obtained from this lovely poppy plant here. All right, we also developed synthetic opioids. And the reason behind developing synthetic drugs was to make them more effective, a clean drug, if you will, with less side effects, and to produce less addictive drug, if you will. Needless to say, that attempt failed. We do have a huge problem in our country, at least with the substance use and so forth. But today we are going to focus on pain management, and not necessary with a substance use disorder. So your role as a clinician to manage someone's pain is to assess the ongoing assessment of, as far as the effectiveness of the medication and possible side effect of those drugs that they're taking. And most of the common thing that can happen to these patients is respiratory depression, especially in elderly population, or somebody who's naive to these medication. So if you have a client whose respiratory rate was a 14 and today is a 9, that tells you that we need to hold onto their next medication dose, if you will. Also, pupils are going to be constricted, increased intracranial pressure, especially in elderly population. You have to be more careful. And nausea, vomiting. Again, if somebody is naive to these medications, opioids will stimulate chemoreceptors in the medulla, and causing nausea, or vomiting. So assess for maybe need for antiemetic medication like Zofran. So if you have a client who's recovering from a surgery, let's say status post knee replacement, and every time they ask for pain medication, they throw up. They took morphine and they threw up, and perhaps we can give them Zofran first so that they can really take the pain medication. Otherwise, they are not gonna walk. They are in pain, and it's gonna really have a negative impact on their overall rehab if we do not manage their pain appropriately. Talking about not able to walk, that itself can cause constipation after surgery, right? Remember, post-op patients are at high risk of constipation to begin with because they got anesthesia and everything is slowed down in the GI tract. On top of that, opioids will increase tone in the anal sphincter and slow down the intestinal peristalsis, further putting these patients at risk for constipation. So always assess a need for stool softener. As a matter of fact, I'm very careful with the geriatric population, especially patients who are recovering from surgery, having difficulty walking because of the pain. Anytime I prescribe pain medication, I usually add a stool softener for these patients. Okay, another concept is urinary retention, very similar to constipation. So instead of GI, here's a bladder. So opioids will increase the tone in the bladder sphincter and by suppressing the stimuli that normally signal bladder fullness. Now we are going to retain. So we might have to assess for potential need for Foley cath, which is not a good practice, by the way. If we have to do it, we have to do it, but offer frequent toileting and then just assess for bladder if it's full, if they're retaining urine. Okay, orthostatic hypotension is a risk for opioids, especially for elderly patients, very at high risk for falls and injuries. So always assess for that. And when you stop taking the medication, assess for withdrawal. Remember, these medications do have a potential for dependency, if you will. So the withdrawals are going to be totally opposite of overdose, right? So the patient is going to be very depressed and anxious, muscle ache. Now you see dilated pupils, not a constrictor. Constrictor is when you take too much. This withdrawal is when you don't have enough. So it's opposite, right? Very tired, sleepy, yawning, insomnia. At nighttime, you have difficulty falling asleep, if you will. Withdrawal usually occurs within 6 to 24 hours, and the client make every effort to avoid withdrawal. In other words, they are going to ask for medication, and we have to be careful. That's it's a principle where you have to gradually decrease the medication. If they were taking 3 times a day, perhaps do 2 times a day, 1 time a day, and so forth, and still have like a PRN, if you will. We have to be very, very careful with that. Okay, so with that, let's start talking about some drugs that fall under these categories. The first one on the list is morphine sulfate. Now, I'm not saying that this is the first line of agent. I am simply saying that that's the first one on the list because it's a prototype drug. Okay, so we compare the rest of the opioids with this prototype drug. So morphine sulfate is a precursor of synthetic opioid analgesic, such as hydrocodone, hydromorphone, oxycodone. We'll talk about that in a minute. So morphine is a standard opioid with which all other drugs are compared, and that's a definition of a prototype drugs anyways, right? The mechanism of action we already talked about. For most of the opioids, the mechanism of action is going to be very similar, right? They're going to bind to the mu and kappa receptors in the brain and spinal cord, and they will alter the perception of pain. and also emotional response to pain. So it will produce that analgesic effect and euphoria. You feel good. Now that doesn't mean that the pain doesn't exist, by the way, right? You're not really treating the pain. You have to treat the cause of the pain. For example, if the cause is that you have a broken piece of glass in a leg or knee or foot, or a part of the body, we still have to remove that. Or if there's a pressure on the spinal cord, we still have to take care of that part. Otherwise, the effect of these drugs are going to be temporary. And the beauty about morphine sulfate is it also comes in a different forms, different routes, if you will. We can give a PO, we can have either immediate release or extended release. So if it's IR, we can give as a PRN if you need the medication right now it will kick in, or extended release for something to manage maybe like a chronic pain that way stays in the system for longer duration. Sublingual, I do that for a client who is on maybe like hospice, and to manage their pain, keep them very comfortable. So these are drops that we can put under the tongue, if you will, or we can give IM injections, we can give them IV morphine, rectal, epidural. So there's so many different routes, and that's the beauty about morphine sulfate. There is a black box warning. It does have a high potential for addiction or abuse, if you will. So it's a Schedule II drug. It's a controlled drug. So I'm sure you know this already. All right, so let's see if you were paying attention. So the nurse is monitoring the patient for adverse effect associated with morphine. Which adverse effect would be expected? Select all that apply. And I know that you love select all that apply question. So you can pause and see if you get the right answer. And the correct answers are number 1, respiratory depression. Remember, we were talking about morphine and we already talked about the side effect. So respiratory depression. It would be hypotension and not hyper, right? Urinary retention, we talked about that, constipation, and of course nausea, remember? Okay, so next is a tramadol. It's a very weak opioid agonist that inhibit the reuptake of norepinephrine and serotonin. So overall patient feel good. Remember, we have already talked about low level of norepinephrine and decreased level of serotonin, the role of that in depression and so forth. Remember, mood disorders. I use a tramadol sometimes as a first line agent. It's not as strong as the Norco, or well, definitely not as strong as morphine, but sometimes I do use this for elderly population. It is a Schedule 4. Remember, morphine was a Schedule 2 drug. So anytime you have a pain medication, especially opioids, you can compare that with morphine. That way you have a better understanding where these drugs stand up against the prototype drug. So this drug has a low potential for abuse. As I mentioned, it's stronger than Tylenol or Advil, so stronger than your NSAIDs and so forth, but not as strong as a Norco or a morphine. It also available as a combination. So Ultram is the brand for tramadol, and if you can combine tramadol with acetaminophen, and you get the name Ultracet, that's acetaminophen part here. So if you are taking, remember this is a prescription drug, right? All of the opioids are prescription drug, but the acetaminophen is over the counter. The patient is already taking acetaminophen, and we are prescribing a combination, then it is our responsibility to let them know, hey, don't go beyond 3 grams of acetaminophen. So cut down on your PRN or Tylenol, if you will. So depending on the milligram they're taking, you might have to sit down with them and give them education how many tablets they can have in a day. Okay, next is codeine. Codeine has a two primary therapeutic effect. Of course, pain. We are talking about pain management today, analgesic, and also antitussive, so cough. About 10% of codeine is actually metabolized to morphine. So codeine is relatively less potent than morphine, though. However, it is more likely than any other opioids to cause constipation. So start with the C, CO with the constipation. One way to remember that codeine can cause constipation. Any opioid can cause constipation, by the way, but codeine has more potential. Okay, PO codeine is as effective as IM or IV parenteral form. It is often combined with a non-opioid analgesic. Remember, I just gave you example of acetaminophen and tramadol, and so we do that a lot, by the way, with the pain medication. So same thing with the codeine. We can combine acetaminophen or Tylenol with the codeine. So we call that Tylenol number 3. Tylenol number 3 simply means that you have a Tylenol 300 milligram. The first part is always acetaminophen, and 3 is telling you that you have a 30 milligram of codeine in it. And if it's a Tylenol number 4, the first part is always acetaminophen, and that number does not change. So acetaminophen is still 300. The 4 is telling you that it's not a 30, it's a 60. We doubled it. Okay, so just remember that part. The first part is acetaminophen that remains at 300. Number 3 simply means is a 30 milligram, and number 4 means a 60 milligram. Just FYI, Tylenol number 3 is more commonly prescribed than number 4. And if you have a client with some like a dental workup and stuff like that, and they will do Tylenol number 3. Okay, it's so codeine can be either Schedule 2 or Schedule 3 and or 5, depending on the milligram of codeine that the patient is going to get. Okay, next is hydrocodone. So the example, so hydrocodone is a generic name. The brand name would be like a Norco. It's a synthetic opioid, and same mechanism of action, of course. And it is also available in a combination with acetaminophen, aspirin, or ibuprofen. A combination with acetaminophen is by far more commonly prescribed. I do that a lot, to be honest with you, for my rehab patients, with my surgical patients. So, for example, remember we talked about combining codeine with acetaminophen, and acetaminophen number was a 300 milligram, remember? And with hydrocodone, we do the same concept. The first number here is actually the hydrocodone. So 5 milligram is the hydrocodone, and 325 milligram is the acetaminophen. With the codeine, it was opposite. Remember, the first number was acetaminophen, like a 300 milligram, and then codeine was a 30 or 40, if it's a Tylenol 3 or 4. Here, hydrocodone 325 is the 5 milligram is the hydrocodone, 325 is acetaminophen, and it comes in a 7.5 milligram as well. And the number of acetaminophen milligram will not change. That will be still 325. And same thing with a 10 milligram of hydrocodone, and 325 is your acetaminophen. These are in milligrams, by the way. Okay, I usually, not always, usually start off with the Norco 325, and if pain is not getting better, may increase to 7.5 to 325. Now, just a side note, remember we have to be very careful for not increasing the total amount of acetaminophen in 24 hours. So if we want to keep, let's say you have a geriatric patient and you want to keep the less than 3 gram per day, and the patient is already taking acetaminophen, maybe, I don't know, 500 milligram, 2 tabs a day, 3 times a day or so. On top of that, we are giving, let's say, Norco 5-325. Very quickly, it will go beyond the 3 grams. So you have to be very careful. And another thing is, if the patient is taking, let's say, 5-325 and taking 2 tabs here, that means they're taking 10 milligram of hydrocodone, but instead of 325, they're taking 650 milligram of acetaminophen, and we can avoid that by giving them, instead of giving them 2 tabs of a 5-325, we can give them just 1 tab of 10-325. That way they still get 10 milligram of hydrocodone, but they do not exceed the upper limit of acetaminophen by going more than 3 gram a day or so. Okay, so those are the things you need to sit down and give a patient teaching, and then how many tablets they can take in one day to minimize the hepatotoxicity issue with acetaminophen. And it is a Schedule 3 drug. Remember, morphine was a Schedule 2. So next drug is oxycodone. Oxycodone is very similar to hydrocodone. It is a semi-synthetic opioid, just like we talked about codeine. It also comes as an immediate release for acute pain, or extended release for chronic pain. Well, we know there's a rule of thumb is anytime we use ER, that medication cannot be used as a PRN, right? It takes a while for that medication to kick in. So ER would be for chronic pain, and we cannot crush, if it's ER oxycodone, we cannot crush, we cannot chew. That means that the patient has a G-tube, but then you cannot really crush this medication and put through the G-tube. Just like hydrocodone, the one that we talked about, like Norco was the brand name. Similar dosage, oxycodone 5-325 or 10-325. 5 is the oxycodone part, 325 is the acetaminophen. Same thing with the 10 being oxycodone, 325 being acetaminophen, and these are milligrams. Very, very similar concept. There are some patients, they'll tell me that they do not like hydrocodone, or their pain is not managed well with hydrocodone, and they actually request oxycodone. For some people, they feel that oxycodone managed their pain better, or it's a little bit more superior. And I actually prescribe hydrocodone far more often than oxycodone, but I do both. All right. And OxyContin is the extended release. So that's a 2 times a day for around the clock. And that's what the ATC is, around the clock analgesia. So remember, OxyContin is the extended release, not IR. And it's a 2 times a day. So Q12 hours, you can say. So it's a Schedule 2 drug, just like morphine was. Okay, so next agent is dilaudid or hydromorphone. Hydromorphone is very potent synthetic compound. How potent? Well, 5 times the potency of morphine. Remember, we are comparing every drug with a prototype drug, and that is morphine. So, for example, 2 milligram of hydromorphone is equivalent to 10 milligram of morphine. Well, needless to say that this medication is reserved for severe pain that is not relieved by morphine. So, for example, let's say I have a patient with chronic pain, and we tried acetaminophen, we tried NSAIDs, we tried tramadol, maybe hydrocodone, which is Norco, and maybe oxycodone, morphine, and my patient is still in pain, and then perhaps next stop can be hydromorphone. I do that for like a client with cancer, or especially like bone cancer, very, very painful. This medication produce less nausea, vomiting, so patient tolerate medication very well. But again, it's very potent drug. It is a very desirable drug among the IV drug users, and therefore it is usually not prescribed as outpatient. And none of my patients in the outpatient setting, with exception of some who are going through chemo or have cancer, will be on these medications. But generally speaking, this medication is given in the controlled settings like hospital or nursing home, if I have to, where somebody else, like a nurse, is giving the medication. With outpatient, we usually do like a Norco or morphine. And I'm not saying that we cannot, by the way, but we try our best to avoid it. But if the patient needs it, like as I said, cancer patient, then then we do prescribe. And this is a Schedule 2 drug with a high potential. All right, next is Demerol. Demerol is a synthetic opioid as well, with less potency than morphine. So now you see where each drug stand up against morphine now, right? This drug, to be honest with you, we are not going to use this, or you're not going to see this to manage someone's pain, if you will. This is usually used for pre-op sedation or maybe post-op pain, but outpatient or generally speaking on the floor in nursing homes, we do not give Demerol. It's not like a drug of choice to treat chronic pain. And the reason behind that is because this medication carries high risk of seizures. Not a good drug of choice for elderly patients, has way too many drug-drug interactions. It is a Schedule 2 drug with high potential for abuse as well. You're not going to see that much of Demerol. Okay, so next drug is the fentanyl. Fentanyl either comes as IV or maybe like a durogesic transdermal patches. We use IV for pre or post-op. It is very potent drug, 100 times the potency of morphine. So remember earlier we talked about Dilaudid being 5 times the potency of morphine. This is 100 times. So that tells you how potent this medication is. So for example, a 0.1 milligram of fentanyl is equivalent to 10 milligram of morphine. So very, very important concept. We have to be very careful when the patient take this medication. Back in the days, we used to give a lot of like a durogesic transdermal patches, especially in the nursing home with the chronic pain management. That has changed a lot, to be honest with you. And then I'm proud to say that none of my patients are, at least not currently, on these patches, or at least I do not prescribe. We can manage pain better with early interventions, and I do a lot of like a PT, like a physical therapy, and so forth. And as we know that overall our nation is struggling with the substance use, and more specifically with the fentanyl. So you have to be very careful. It's a Schedule 2 drug. When you have a client on transdermal patches, they're good for 3 days, and we need to change the patch and change the location as well. If it was on the right side, right upper chest, and then maybe put that on patch on the left side, and so forth. Okay, so that's that with the fentanyl. Okay, so next stop is methadone. Methadone is also a synthetic opioid. We usually prescribe this for the treatment of opioid detoxification. The respiratory depression is a major concern with this agent. And also, I remember we talked many weeks ago about the role of cytochrome act as a substrate. So we talked about drug interaction. So methadone is also one of the examples for that. It can prolong a QT interval, and we always get a baseline EKG, and we monitor frequently while this patient is taking methadone. And it is a Schedule II drug. Okay, so we are done with the opioids or narcotics, if you will, and now what can we do if you have a client who either again intentionally or accidentally took too much of those medications? So we have a reversal agent, naloxone, Narcan. It's a fast-acting medication that will reverse the effect of opioid overdose. It is a short-acting, so in other words, you may need to repeat the dose based on the amount of medication the patient took. Now the next agent is naltrexone. Naltrexone is opiate antagonist used for substance use disorder, either opioid use disorder or maybe alcohol. So if you have a client who was taking, let's say, some kind of opioid for years, and we want to stop that, we want to treat that substance use disorder, we can put them on naltrexone. It's a PO drug or daily or once monthly prescription to treat relapse or prevention maintenance therapy, I should say, right? Please understand, naltrexone will not work in overdose situation. In other words, if you have a patient who took too much morphine, let's say, or any opioid for that matter, naltrexone will not reverse it. We still need naloxone for that, okay? So naloxone is used to reverse because that's a short acting. It will work right now, right? Naltrexone is used to prevent the future use, to decrease the desire to take that drug again. So the reason I'm sharing this with you is if you have a client who was on, at one point there was a substance use disorder, let's say the patient was taking 10 milligram of Norco, hydrocodone, right? 10-325, right? 325 is acetaminophen, we know that. So let's say a patient was taking this for years and we put them on naltrexone, and now the patient is admitted to the hospital, maybe after accident, or maybe it's a surgical patient, status post-surgical patient who needs to be on opioid now to manage their acute pain. Then we need to stop or hold naltrexone at that time and give them pain medication. So two important concepts. Number one, we would hold naltrexone, otherwise the pain medication will not be effective. That's the first principle. Second is, because the patient was on naltrexone, instead of 10 milligram, maybe that's what they used to take back in the days, right? 6 months ago, a year ago, we need to start them on a lower dose, like a 5 milligram instead of 10, because after taking naltrexone for some time and then stopping it, like today, let's say, patient may be more sensitive to even lower doses of opioids, and therefore we can put them at high risk of overdose if they start taking opioids when they were on naltrexone for a while. So we are going to start them at a lower dose and hold naltrexone at that time. Now, you may have a client with some kind of nerve pain and may not be a good candidate for opioids. And for those patients, usually the best treatment is gabapentin. Neurontin is a brand name. Gabapentin is actually anti-seizure medication. It's not a great anti-seizure medication, to be honest with you, but we found out that it can actually help with the nerve pain. And nowadays, most of the time, gabapentin is used for neuropathy and not necessary for seizure. When I lecture on a seizure medication, we'll talk about voltage-dependent calcium channel and how these medications can block. I have a lecture coming up for seizures. Some medication block the sodium channel, some will block calcium. But today, just understand that this is anti-seizure medication that can be used to manage nerve pain. This medication can cause some drowsiness, dizziness. I usually start them on this medication at night time, and that way, and give them patient teaching that be very careful tonight, and especially if elderly patient have to go to the bathroom at night time, so be very careful to prevent any falls. And if they're tolerating very well, then I can titrate up based on that. Maybe next day take it during lunchtime. Now it's 2 times a day, lunch and dinner, and the next day maybe 3 times a day. Usually it's like a 300 milligram 3 times a day or so. And for some patients, gabapentin is not as effective, and we can use Lyrica, pregabalin. Again, we'll talk about these medications more during a seizure lecture. But Lyrica is more expensive than gabapentin, and you may have a patient who is going through some maybe chemotherapy, and some of the side effects for some chemotherapy they can cause a neuropathy, or even after stroke, CVA, status post CVA, patient is telling you that I have numbness and tingling, or even diabetic neuropathy. I sometimes switch them from gabapentin to Lyrica and then see very good results. Okay, let's see if you are paying attention. Patient with diabetes reports increasing pain and numbness in his legs. He says it feels like pins and needles all of the time, especially at night. What drug do you expect to be prescribed for this client? Number 1, ibuprofen. Number 2, gabapentin. Number 3, morphine. Number 4, methadone. Number 5 is naloxone. I'll give you 3 seconds to pause and give me the answer. Okay, well, hopefully you picked gabapentin, Neurontin for neuropathy. All right, so next is, remember now we're talking about like a miscellaneous drugs, some like add-on drugs, if you will, right? We can use SSRIs or SNRIs. For example, Cymbalta. We talked about Cymbalta in depression lecture, that duloxetine is generic name. We can treat all different types of pains with the Cymbalta, right? Maybe arthritis, maybe depression with the pain, or just pain itself, and neuropathy even, pain without depression. So Cymbalta is a good SNRI for chronic pain. All right, we talked about that. Usually we start with a 30 milligram 2 times a day, and then go to 60 milligram 2 times a day. Max is 120 milligram per day. And then we can use some muscle relaxants. Once in a while I'll use like a baclofen, if you will. Muscle relaxants do have some sedating effect, so I have to be very, very careful, especially with a geriatric population. Again, maybe they need massage or heat or ice therapy. One time I remember I referred a patient who was on very high dose of a muscle relaxant and narcotics, and so I got that patient from a different facility. And when we did physical therapy with the application of some ice and stuff like that, we were eventually able to discontinue their baclofen and also decreased, I believe he was on hydrocodone at that time. and totally different personality, by the way, when we discontinue these medications that cause sedation, dizziness. You can imagine a quality of life. But I also understand the role of muscle relaxant at the same time, by the way. I get that. So you have to be very careful. Start them on a lower dose and a monitor, and then the role of those non-pharmacological interventions, like I mentioned, physical therapy or exercise in general, yoga, whatever, music therapy, and so forth. Okay, so the next is migraine headaches. To be honest with you, migraine is very still poorly understood, topic. We believe that serotonin 5-HT receptors are located in the extracerebral and intracranial blood vessels, and they become dilated during the migraine attack. So it's a dilation of those blood vessels, especially with the serotonin receptors, causing the episodes of those migraine. Now, for some patients, headaches are mild or not significant enough that they don't have to do anything, just lay down, take a nap, and that helps close the windows, minimize the sunlight, if you will. But some patients may need acetaminophen, and that helps. Maybe aspirin, caffeine helps in some clients. But there are some patient where they need medical management, prescriptions, especially when they have a nausea, vomiting, photophobia. There's also a concept of migraine with aura. That means they know that it's going to happen, it's going to come, and they can take the PRN medication at that time. But generally speaking, we can divide the migraine management protocol in two main categories, and one is abortive treatment and second would be preventive. Abortive means we can give something to get rid of that episode, abort the headache. And the class, the agent that helps with abortive treatment is triptans. They end with a triptan. So sumatriptan, a very common drug, Imitrex is the brand name, structurally very similar to serotonin itself. So it will activate the vascular serotonin receptors, 5-HT1 receptor, and produce vasoconstriction. And remember here, the pathology, we were saying that it may be due to vasodilation, right? So we are going to constrict that. And the beauty about triptan is not only it actually abort the headaches, but also minimize some secondary symptoms that comes along with the headache, such as nausea, vomiting, photophobia. So that's a a good thing for these patients. Okay, preventive care is where we ask the patient to create a log sheet and come up with some triggers. What is causing those episodes, if they can identify. As I mentioned, some people have aura, and then they can say, okay, gosh, it's going to happen, and I know what I was doing earlier. Maybe it was a chocolate or light, or like a photophobia and so forth. So if they can come up with a trigger, with a list, I should say, and then avoid those triggers. Now, for the preventive medication approach, we use beta blockers. Propranolol is a drug of choice. I use that a lot. Just recall that propranolol is actually a hypertensive medication, and we sometimes use that for tremors as well, sometimes for anxiety, to calm you down. So here we are using propranolol for migraine. All right, so but keep an eye on their blood pressure and heart rate. Sometimes we can use a calcium channel blocker and ACE inhibitors or ARBs. This is a seizure medication, Topamax. We'll talk about that in seizure chapter. Antidepressant medication, amitriptyline can be used. Your seizure or mood stabilizer like valproic acid, and then here's the gabapentin. Actually, to be honest with you, gabapentin along with the propranolol, I've seen this a lot, and even amitriptyline for preventive measures. And sometimes we can consider estrogen for menstrual, migraines episodes. Okay, patient teaching for triptans in general, not for just for this medication, but generally speaking, these medications are PRN. Again, the goal is to have a client on preventive medication so that we do not use triptan throughout the day or throughout the week or so. Okay, so typical patient teaching would be take 25 to 100 milligram PO one time and may repeat the dose one time after 2 hours. So if you took at 9 o'clock or so, wait for 1 hour and may repeat in 1 hour, like 10 a.m. But max dose is 200 milligram in 24 hours. So if you took 100 milligram the first time and you did repeat the second time, you met the max for that day. So very good patient teaching. And so that's PO. For intranasal, it's a one spray into each nostril. The client can repeat this a single time after 2 hours as needed. Okay. The drug has a rapid onset and peaks in 90 minutes or so. So we should be getting the relief, at peak. What are the side effects? Mild, transient nausea, dizziness, and vertigo. After taking the drug, the client should lie down and rest in a quiet, dark, cool place for 2 to 3 hours. So minimize all the triggers, if you will. The intranasal spray may irritate the mucosa of the nostril and throat, and has very unpleasant taste and can cause nausea. So these are all patient teachings. Serious cardiac event due to vasospasm. Check blood pressure and report hypertension to the provider. This is not something that you just want to ignore. So remember, we are causing vasoconstriction here. That's the whole point. So if you cause too much vasospasm, you can increase your blood pressure, and that's a phone call to the provider. All right, let's see if you are still awake or not. Patient with migraine headaches took sumatriptan, Imitrex, for the first time yesterday. Today he is telling you that after taking the medication, he began to experience some chest pain. The patient further states that the drug was effective in relieving the headache, and you should, number one, encourage the patient to continue using the drug because it was effective. Number two, advise the patient to tell the healthcare provider about the chest pain at the next visit. Or number three, instruct the patient to contact the healthcare provider right now to report the chest pain today and not to use the medication until talking to the healthcare provider. Number four, encourage the patient to lie down in a quiet room and use cold packs during the next migraine. You can pause for 3 seconds or so and then give me the answer. And hopefully you picked option number 3. Instruct the patient to contact the healthcare provider and report the chest pain today, not next time. Okay? Even if the medication is very effective, we still need to intervene because of the side effect of these drugs. Remember, they are causing vasospasm, or they can cause vasospasm. Next question is, you're taking care of a client with a migraine headache in the ED. Which of the following drugs would you anticipate giving to prevent the patient's migraine? Select all that apply. Number 1, morphine. Number 2, propranolol. Number 3, ibuprofen. Number 4, gabapentin. Number 5 is sumatriptan. Again, pause and please come up with the answer. Hopefully. And the right answer is propranolol and gabapentin. If you selected number 5, then you were thinking of abortive treatment. This question asks for preventive measures, and that would be propranolol and gabapentin. All right. One more question. The nurse is caring for several patients who are receiving opioids for pain relief. Which patient is at the highest risk of developing hypotension, respiratory depression, and mental confusion? Number one, a 23-year-old female post-op ruptured appendix. Number two, a 16-year-old adolescent post-motorcycle injury and lacerations. Number three, a 54-year-old female post-myocardial infarction. And number four is an 86-year-old male post-op femur fracture. So pause and see if you can give me the answer. When you try to answer these kind of questions, pay attention to the age of the patient and the comorbidities or severity of the situation. So keep those things in mind. And hopefully you picked an 86-year-old male with a post-op femur fracture. Now, it's not just the age here. Age is one factor, by the way. So we are dealing with hypotension, respiratory depression, and mental confusion. And this person is taking, well, all of them are taking actually opioids. So pretty much all patients were actually at risk of respiratory depression, if you will, right? But who is at higher risk out of all the patients for just respiratory depression alone? And that would be either an 86-year-old, or if I had, I don't know, 8-year-old or 6-year-old, right? So younger, a child or adolescent, and then the elderly patient. 16, okay, maybe, but still old enough, almost an adult. But I can see that. But the issue here is some more comorbidities, especially mental confusion as one of the risk here. So who is at high risk for mental confusion? Well, when you have a client with post-op femur fracture, the client is at risk for either blood clot, PE, or sometimes even fat embolism, with the femur fractures. And that is the reason why I picked 86-year-old, not just because of age, but because of the type of a fracture, versus appendix and young client is going to be able to ambulate and not going to be at high risk for mental confusion or hypotension. Again, in my opinion, post-op femur fracture, high risk for blood clot, issues with ambulation, putting them at high risk for either fat embolism or just blood clot in general, and taking opioids at the same time. All right, I think that's all I have. And as usual, feel free to contact me if you have any questions or concerns, and I'll see you next time. Thank you.